Well, thanks, Alan, and thanks for inviting me. It's a good opportunity to engage with this, audience, which is, I think, a very important mix of people at this time, which is going to be so critical for shaping the future. The examination question I've been set is, in the 21st century, the link between those that are economically disadvantaged and poor health still exists. What can be done to eradicate this? So in 20 minutes, we'll sort that one out. The links between poverty and ill health are by now well known and rehearsed almost to the point at which they're no longer heard. The British tradition of research in this area, from Rowntree to Townsend, Black, Jerry Morris, and now Marmot and Wilkinson, has been very influential and has periodically raised the profile of the issue politically and more widely internationally, as well as locally, and has played into global issues of health and development, international development. The Victorian public health movement itself arguably had its roots in the publication of Chadwick's report on the sanitary condition of the labouring classes in 1832, whose findings also resonated politically in Engels' treatise on the conditions of the labouring classes in Manchester and Dickens' novel Hard Times. Our understanding of the description of the links between poverty and ill health has progressed in steps that have taken us from an appreciation of where poverty fits into the life cycle, through child poverty, the poverty of working class families with large numbers of children, and the poverty of disabled people, infirm and aged, to one where Wilkinson and Pickett have shown quite convincingly that at a population level within societies, states and countries where there are the biggest differences in income are also to be found the biggest differences in health, notwithstanding average income levels. So the United States, which is one of the wealthiest countries in the world, has some of the biggest differences in health status between the population. Going beyond the descriptions, the problem can seem insuperable. Despite massive increases in public expenditure over the past 13 years, and despite some impact on child poverty, inequalities in health can seem stubbornly resistant to change. And we're uncomfortably reminded of Jesus' comment in Matthew 26, verse 11, that the poor you will always have with you. Yet does it have to be like this? And how might we make an impact through policy and action at the societal and personal and local levels? Some clues may be found in Richard Wilkinson and Kate Pickett's recent book, The Spirit Level, which identifies some places and times when real increases in inequality have occurred, such as Bismarck's social insurance scheme in Germany in the 19th century, and Britain during both the First and Second World Wars, when social solidarity was taken as a prerequisite for military success. Quoting Richard Titmuss, Wilkinson reminds us that if the cooperation of the masses was thought to be essential to the war effort, then inequalities had to be reduced and the pyramid of social stratification had to be flattened. If Wilkinson reminds us that relative poverty is as relevant in its own way as absolute poverty, Titmuss took us onto a different plane when it came to poverty itself, by teasing out what it is about money as a resource for everyday life that makes a difference. Money, like God, only means something if people believe in it. Otherwise, it's just paper or metal pieces. What money can do is give access to those other resources which impact on health and well-being. And for Titmuss, a narrow focus on money could be misleading. For Titmuss, control over resources through time was the real issue. Access to good parenting, choosing your parents wisely, a safe and nurturing environment, educational, cultural and work opportunities, recreation, a sense of worth, a secure home and security in old age, oh yes, and access to good preventive treatment and care services when needed. These were the real resources that led to commonwealth, economic success, and a society at ease with itself. This was captured by Beveridge in 1942 in his 5 giants: want, ignorance, idleness, squalor, and disease, which pointed to the 5 pillars of the welfare state. It's important to remind ourselves that coming out of the recession of the 1930s and the carnage of the Second World War, the vision of the welfare state more or less enjoyed a political consensus between parties for the next 30 years. What we now know is that a focus on the what without the how, without addressing people's need to be engaged and in the driving seat, can lead to enormous waste and counterproductive initiatives, usually carried out for the best of intentions, but often vulnerable to the accusation of paternalism, nannying, and the like, of wanting to fix people, whether they wish to be fixed by somebody else or not. We'd only have to look at the mistakes of slum clearance in the 60s and 70s, or more recently, perhaps the large amounts of money that have gone into the health service and have finished up in acute care, largely, very little going into public health or prevention. So what is it that makes a difference? The backcloth of inequality remains, but it's time for the conversation to move on. We need to reframe the 5 giants for the 21st century and ways of doing that are emerging. The Marmot Review concluded that reducing health inequalities will require action on 6 policy objectives, and I expect everybody here is very familiar with those. To give every child the best start in life, to enable all children, young people and adults to maximize their capabilities and have control over their lives, to create fair employment and good work for all, to ensure healthy standards of living for all, to create and develop healthy and sustainable places and communities, and to stress then the role and impact of ill health prevention. So far, so good, but in a sense, these conclusions still seem to be at a high level of abstraction, and to some would appear to be statements akin to motherhood and apple pie. A reading of the literature already referred to, from Chadwick, Dickens, Rowntree to Titmuss, Townsend, Douglas Black, Jerry Morris, would also indicate that these comments are on a well-trodden path. Some clear policy objectives and campaigns are, however, emerging. For example, the achievement of a minimum wage now, leading on to the movement now towards a living wage. A recognition that we must do something to achieve universal excellence in education so that all children have opportunity and fulfilling work, not so that we can be ready for war with Germany, but so that we can compete economically on a global scale. That respect for the environment that nourishes and protects us must be taken much more severely if we are not to threaten the well-being of future generations. That services that make a difference, whether they be preventive medicine, health protection and health improvement, or health and social care, need to be of a universally high standard if we're to avoid the burden of unnecessary ill health and optimize the productivity as well as the well-being and happiness of the whole population. But the new kid on the block is that of ownership and locus of control. People having the opportunity to be in the driving seat of their own and each other's destiny, rather than having things done to them from on high. Paternalism is no longer enough or fit for purpose. For the coalition government, this has led to talk of the big society. But what does this mean for those of us who see society through a public health prism? I'd like to take a couple of minutes to refer back to the Victorian public health system and draw out some of the lessons for the current proposals for public health and health and social services. As we sit poised on the edge of yet another major upheaval of the arrangements for health, well-being and public health, it's worth reminding ourselves of the journey we've trodden over the past 200 years, the systems we've had and the aspirations for the future. The Victorian public health system grew out of massive social upheaval as we moved from an agrarian society to an industrial and urban society. Disruption of the parish system meant that the support wasn't there for slum dwellers living in poverty and squalor.